Okay, so for this section here of ICP, it's all going to involve neuro. I have a picture of cranial nerves. You don't have to memorize it. But if you, at some point, for whatever reason, need to memorize it, there might be some Kaplan questions, and then at most maybe like one or so questions on the NCLEX. It depends on your individual NCLEX, but you might actually get asked about cranial nerve. But for the class, I don't believe they're going to ask you about cranial nerves, but you might get a question like it on the Kaplan. But um, this is something that you can use to kind of reference back if you feel like you want to learn them for the Kaplan. There are videos on easy ways to memorize it that you can watch. Okay, so as with everything here, the cyan, blue, green, it's like extra information, and the things that I feel are the most important are going to be in yellow. General overview here, like showing like the brain, the cerebrospinal fluid is enclosed in the skull, and there's that 20% that is the cerebrospinal fluid and vascular supply, and then the brain. So both of those together is like creates like a pressure in the skull, and that pressure is your cranial pressure. ICP is specifically referring to increased cranial pressure that occurs when one of those things is out of whack. For a lot of these conditions, the the end result is going to be that the brain is going to be lacking in oxygen or in glucose. Oxygen has no reserves of either one, so anytime you're down under, unable to get oxygen in, unable to metabolize, you're gonna be going without true proper perfusion, and that's could lead to brain damage. Okay. So your cerebral perfusion pressure, your CPP, this is the blood flow that um, brings O2 to the brain tissue. You are gonna need to know the values associated with that. Does anyone know the value and the overall formula involved with CPP?
The formula is MAP minus the intracranial pressure, right?
Yes. So CPP is MAP minus ICP. Your MAP wants to be around 70, 65 plus 70. What is the normal value for your CPP?
Is it between 50 and 100?
15, 50, and 100, yeah. And then anything less than 40 is considered um, more critical slash you got to put more attention to it. So for CPP specifically, 50 to 100. For your map, you're gonna want to know your formula for your map. At the top of your head. So do you guys still remember it? I think it's come up a few times already. Okay, so yeah, so that's diastolic plus your systolic, all divided by 3. So 2 times your diastolic, add your systolic, and then divide by 3. Okay. Then your ICP. Your ICP is, like I mentioned before, it's made up of the pressure between, well, your intracranial pressure um, is made up of the pressure between your brain, your cerebrospinal fluid, your vascular supply. Donnie mentioned the normal value 7 to 15 might differ where you're coming from. I have it written as 5 to 15, but that's approximately around the same ballpark. And treatment is usually gonna want to start when it is approaching about 20 or more. when it becomes imperative that you do something about it. So when it is going to be at this value for a long period of time, it's going to potentially lead to tissue damage, midline shift, meaning that the position of the brain, where it should be aligned in the middle, is going to be shifted to one side, which is obviously not good because that's a lot of pressure being put on the brain that's going to cause damage. It's going to cause swelling, and after a long period of time, that's just going to um, the person could go in a coma because part of their brain is just straight up not working, might have difficulty breathing on their own. I have a list of things that increase your ICP. Don't have to directly memorize any of this kind of stuff, but there's stuff here. So what I do want you guys to know is your signs and symptoms of increased ICP. So what are some things that would come up that would be signs that that pressure is increasing? And then there's one in particular that's very important to have memorized.
Like altered level of consciousness,
Hmm.
and also like cortical changes like speech changes,
Hmm.
and then pupillary changes as well.
Hmm.
Any motor abnormalities like unilateral weakness.
Hmm. Okay, so that covers
And
most of that.
Cushing's triad as well.
Yeah. So what is Cushing's triad?
It's when there's wide impulse pressure, or when the systolic blood pressure is very high,
Hmm.
and when there's bradycardia as well as abnormal respirations.
Exactly. So, so I'm gonna highlight this one because this one needs to be, because a lot of your questions are gonna kind of hang on by the idea that you're trying to assess if the patient does have Cushing's triad or not. So you'll have questions that kind of hinge on that. Let's see. And then Donnie also mentioned the drowsiness and the vomiting, visual changes, people changes. This arthria meaning difficulty speaking due to like um what's it called? Difficulty speaking due to like more muscular weakness type of thing. One of your first signs is going to be your altered level of consciousness. So that's going to be like a big one. Agitation, restlessness that kind of come with the territory, the level of impairment, lethargy, a little bit of tiredness, obtunded, like getting difficult to arouse, and then coma, unable to arouse. Um, I made a specific thing here where like the what does it mean by wide pulse pressure? Like about 60, difference of like 60. So maybe like could be like a systolic of like 180 with a diastolic of like 60 or something like that. And of course, that's a very big difference. Okay. The cool thing about it is that because we found out up here that it is this kind of formula right here, your overall CPP is going to be a measurement of your MAP minus ICP. You can try to equalize that through different ways. We can either adjust the MAP through vasopressors, um, yeah, through vasopressors, or we can manipulate the ICP either through things like mannitol, which is an osmotic diuretic, to try to decrease some of the fluid shift that's going to the brain. Um, a drainage device like an EVD, which is something that gets inserted into the brain in order to drain some of the cerebral spinal fluid. Because remember, part of that ICP is the pressure on your skull due to your brain itself, the cerebral spinal fluid, and your vascular supply. So maybe you do something to kind of drain some of that blood or cerebral spinal fluid out through an EV shunt. So drainage, draining some of that out to relieve some of the pressure. Your head of the bed being up. If your head of the bed is up, you're allowing gravity to um, try to drain some of that pressure down. Things that are going to be able to indirectly manipulate, or at least indirectly uh, are going to cause increases and you want to avoid would be things such as straining. So anything that causes straining. So that would be like a straining bowel movement or um, coughing or vomiting. Pain could cause some straining. So things that would indirectly allow for the decrease in straining and stimulation would be recommended. Any questions on this part of it so far? So the most important things is knowing your values, knowing the formula here, knowing your formula here, and your signs and symptoms, and absolutely you need to know the Cushing's triad. Okay. This is like a quick review of stroke from last semester. So for stroke, stroke is one of the things that can cause increased ICP due to the causing the cerebral edema. So one of your ways to kind of make that initial judgment call is through the BFAST acronym. So changes in your balance, difficulty balancing yourself, visual changes, facial droop, arm weakness, speech difficulty, and then the T is kind of like time to call 911. This person shouldn't be driving themselves. You should call an ambulance in case things start to crash. Um, if they're ever asking like specifics, your arm, like when you're doing like the checking for arm weakness, it should be like arms extended out with palms facing up. So when somebody has noticeable weakness in one arm and you have their palms facing up, you'll be able to very clearly see like their arm um, from the weakness, their arms start rotating with their rotating so that their palms are going back, looking down. So you'll get to see both the arm kind of decrease down, but you'll also see the rotation of the arm. So that one's a little bit more accurate, um, an accurate way of determining that. So always your ABCs are going to be the most important thing when somebody gets there, and your most important thing after that, after the maintaining of the ABCs, is going to be getting a CT of the head, uh, because you have to be able to determine if it's a hemorrhagic stroke or an ischemic stroke, because the treatment is going to be completely different. Your ischemic strokes are going to want to be treated with um, fibrinolytics, so clot busters. It's going to want to be treated with anticoagulants. While your hemorrhagic stroke, the entire reason that's happening is due to a burst in an aneurysm or a blood vessel, too much pressure leading to a bursting of the bursting of the blood vessel. So we're not going to want to make that even worse. So, but that is very important. So it should be done within 25 minutes and interpretation within the next 45 minutes. Everything should be done within the hour if possible. And one of the other things for stroke that they're always going to ask is last known well time. So last time the patient was known to be well, because that also kind of lets you know what the severity of it is. Um, when it comes to like a stroke in the hospital, the good thing is that you have people monitoring the patient that are more likely to catch an early stroke versus at home where there's a chance that it's going to be a little bit on the later end that it gets caught. And then to a certain extent, depending on how late it's caught, some of the treatment might at some point not be appropriate because it's like they already went, like they already kind of went past it. Something that I think at some point you'll be tested on is your Glasgow coma scale. So people in the ICU, this is something that gets calculated, or even on like maybe a little bit more higher acuity floors will get calculated. Um, in my class, they had us memorize it for like one of the test questions. I don't know if they're gonna actually provide you with the scale for your class. I feel like there's no reason to have to memorize it, but this is basically what it's about. It's about how are they able to open their eyes when you respond to them? Do they need to um, do they just open it on their own? Do they need to hear speech? Do they need to respond to pain? Like you have to pinch their like traps or sternal rub, or they have no response at all. And this is like well, I guess this one says child, but child and adult. Um, the best verbal response, so like when you talk to them, are they able to respond back to you? They're fully oriented, or are they confused? Are they um, making noises that aren't words? Are they kind of word salad? So they're saying words, but they're not making any sense. And then the next one would be obeying commands. The only like physical response is to pain. The only physical response to pain is then withdrawing, as opposed to like kind of localizes to pain, meaning like they're fighting back. So like you pinch their traps and they kind of inherently just kind of start swatting at you. Abnormal flexion to pain and abnormal extension to pain is referring to different these different positions here. So the corticate, which is the flexion to pain. So responding by having those arms kind of going in, toes extending outwards, versus the flexion, which is the cerebrate, which is arms kind of like going into themselves and then being stretched out, feet stretched out. And those are signs of very severe brain damage. Here as well, it does have like a little guide of the possible um, possible brain damage that would be indicative of your numbers. So the lowest you can possibly get is a 3. So that's signifying severe brain injury. Person is possibly brain dead. Okay. So some causes of stroke, we have ischemic or embolic strokes versus hemorrhagic strokes, and here are some of the things that cause all that. Um, After a stroke, there's going to be swelling of the brain, maybe afterwards, or the bleeding causing an increase in your ICP, which will then, based on that formula, since it's being subtracted from the map to make your CPP, will lead to a decrease in your cerebral pressure. Like I mentioned before, your brain's going to be deprived of O2 and glucose, which we don't have reserves for, so that's going to lead to ischemia. And as well, due to the lack of that, your body's going to have like a sympathetic surge. So it's going to release the chemicals like norepinephrine, epinephrine, dopamine in order to try to drive blood back into the brain. So there is such thing as like permissive hypertension orders. So a patient might have a permitted high blood pressure because they need higher blood pressure to make sure that stuff is being properly perfused. So that's something worth keeping in mind if you have a patient that has had a stroke or for whatever reason has like permissive hypertension that you're not keeping their blood pressure at lower, like you don't want it at a 120 over 80. They might want their blood pressure to be between like 150 and 160 systolic. So it's what's keeping in mind because you might accidentally give out like a blood pressure decreasing med, thinking that like, oh, that's I'm supposed to decrease the blood pressure, but they need that increased blood pressure to get blood flowing. Okay. So overall, in the care of neuro patients, you're going to focus on your ABCs. With your Glasgow coma scale, if that number is less than 8, which signifies severe brain injury, they're going to want to be intubated because at that point, they're not really going to be able to breathe on their own. ABCs includes assessment of the oxygenation, all that kind of stuff, changes in respiration, management of like, I guess I'll include permissive hypertension, maybe temperature management. People might be on cooling measures. The mini mental exam, which is your assessment of their affect. Affect kind of being like how their face contorts, like are they able to properly express their emotions and what it matches what they're saying if they're able to talk, matches what they're saying, or is it like a restricted? They're not really able to um, express like whatever emotion that they're actually feeling. Their face doesn't really show it. How are they behaving? Are they confused? Are they baseline? Um, and then their cognition, behavior and cognition kind of similar, like, or behavior could be like abnormal, bizarre behavior that is abnormal for them. So like maybe they're just really agitated, really irritable, which is completely different, personality changes, that kind of stuff. Similar to I guess what was done in psych in that front. So for the positioning, we did already talk about it. What is the things that come to you when it comes to positioning?
Head of the bed up, as well as keeping the neck midline and avoiding excessive hip flexion.
Perfect. So we're gonna do head of the bed up. Head of the bed up. I think that's supposed to be, yeah, I think that's not supposed to be 30. It's supposed to be, yeah. So to decrease ICP, we're gonna prevent hip flexion. No big drastic movements, and we're definitely not gonna do a Trendelenburg because then we're putting all of that pressure back into the head, which is the exact opposite of what we want to do. The pupillometer, this is some an assessment that gets done only in the ICU. Okay. This big ass machine that you put up to the eyeball in order to measure your eye pressure, as well as not eye pressure, sorry. I think it can do that though, but it's primarily to kind of get an idea of the size of the pupils, like a very accurate difference between the size and the pupils. I think it also does pressure here. The MPI, I think, is the pressure. But it will allow you to see if there's a big difference between the size of the pupils, and then up to a certain number can be considered normal. And then at that point, when somebody has a big difference in their pupils between the left and the right, it's indicative of brain damage. If their pupils are fixed, like fixed open or fixed closed, that's also a sign of brain damage because at that point, their body's not able to self adjust their how dilated their pupils are. You want to decrease stimuli, decrease stimuli or any additional straining or stressors. So again, mentioning back the stool softeners, Sofran, manage the blood pressure, which is dependent on are we decreasing it because it's too high, like it's above the permissive part of it, or we're trying to keep it at that 150 to 160 or whatever the permissive hypertension management is. One of the things that I think doesn't really come to mind very often, but is relevant for these type of patients is like they're gonna a lot of people here are gonna be ventilated when they have like severe like brain damage due to like a really bad trauma, really bad hemorrhagic stroke. Is like the buildup of CO2. CO2 is a vasodilator, so that's one of the reasons why like if you're breathing in smoke, like cigarette smoke, it might cause you to get um, a little bit lightheaded. So nicotine is like vasoconstricting, but the carbon dioxide uh, is vasodilating, so that can cause an increase in blood flow, which would increase your ICP, which then can give you that lightheaded feeling. But for these type of patients that are going to be on a ventilator, they're going to have ABGs drawn at a interval or whatever interval. They might want to be hyperventilated in order to decrease the CO2 because decreasing the CO2 will cause a um, decrease in their ICP, or at the very least will prevent a further increase in their ICP. So I think this is something that is worth keeping in mind here. It could come up as a question. In my class, he did emphasize it a little bit uh, with his lecture. And then, of course, seizure precautions. At this point, we should have that memorized, but what do you have for seizure precautions?
So things like padded side rails, oxygen at bedside, suction at bedside. Yeah.
Yeah, perfect. The only thing is anticonvulsants, but that's kind of self-explanatory there. Perfect. Yeah, so there we go. Um, Most likely sedate. They're going to be sedated and intubated. Like I mentioned, there's temperature regulation. So a lot of times it's a neurological fever is what they call it. So they need cooling measures in order to kind of help decrease some of the swelling, but also to kind of allow the brain to kind of allow like me your body mechanics to be a little bit slower, allow for be more permissive with the oxygen demand and whatnot. Uh, if it is a neurogenic shock, they actually want to increase the temperature, but for this lecture, the ICP, it's going to be mostly related to, not going to be related to neurogenic shock. It's just going to be more of this. So it's going to be more of cooling measures than anything. And then your reflexes, here's the example. So like the corticate versus the cerebrate. Both of these are indicative of brain damage. The decerebrate is extra bad. That's going to be a worse injury and it's going to have worse outcomes as opposed to the decorticate, which has a better prognosis. But regardless, both of these are abnormal because, as we mentioned in the classical coma scale, they end up giving you this score on the motor part of it. There's something called doll's eyes, the doll's eyes reflex. So what this is inferring to, this is an assessment for comatose patients specifically. So you would open up their eyes and then move their head around. Um, what is expected to happen is that if you move their head to the left, their eyes will move to the right. Basically, their eyes will kind of shift automatically to the center. And that is considered normal. If you turn their head and their eyes move with them, that is very, very bad. That is indicative of a spine injury, a spinal cord injury, brainstem injury. That is abnormal. But having the doll's eye reflex is what they call it, doll's eye reflex, that is normal. Next thing is the Babinski's reflex. This is something you've heard about in pediatrics. The thing is that when this Babinski's reflex, which is the toes extended upwards, the big toe can fan out. Um, but that is in response to like the bottom of the foot being brushed or kind of being kind of go like up to down. That is considered abnormal in adults. It's indicative of brain damage. So for an adult, they want a negative Babinski reflex, which is the toes curling downward in response to um, being brushed on the bottom of their foot. If they show the Babinski's reflex as positive, again, that's a sign of brain damage. But if they're a baby, then the positive Babinski reflex is expected, and it's what you want as opposed to this. Okay, so for the diagnostics, basic basic labs. A lot of the ICP stuff is gonna increase your risk. Like, let's say someone has increased ICP, trauma, all that stuff. They could have another stroke if that's what they came in for. But regardless, like having blood pressure be super high increases your risk of stroking out, hemorrhagic stroke, increases risk of throwing clots. All that stress increases your risk of throwing clots. So coagulation panels are important. Getting an ABGs, a lot of these people will be intubated, so getting ABGs is important. Sometimes the reason that they're so down is maybe they're actually having like heavy metal toxicity or something like that. By the time they're in the hospital, they should have been giving like if like they suspect it, they would have been given Narcan by now. So that's something, but it's regardless something that can be done. And like I said, transferring to imaging is very important to do it as soon as possible. For your medications, the ones that are going to be the most important to know are mannitol, 3% normal saline, also known as hypertonic saline, HTS, and the Diamox, the acetazolamide. So the mannitol is a osmotic diuretic. It's going to be used to decrease the swelling in the brain. So the idea is that this is actually a very, it's actually a sugar because it ends in OL. So the infusion of this is going to cause the osmolarity in your perfusion and your circulation to be increased, which is going to cause fluid from cells to want to rush into the circulation. So swelling that is occurring in the brain, some of that fluid shift will go back to the circulation because of the mannitol. This is something that is, because it's in the name, osmotic diuretic. This is going to be requiring that the patient is able to urinate, is going to be urinating out some of that fluid. So it's not going to be appropriate for someone that is unable to pee or that has really significant renal impairment. And mannitol in particular is good for very rapid reduction of ICP. And because it's a rapid, it's like rapid infusion and there's a risk of extravasation. They're going to need a large bore or a central line because it is so effective at drawing stuff in. If it gets extravasated, it might cause the fluid shifts to cause like ischemia in whatever area that it extravasates to or infiltrates. So for some of the things to monitor, we mentioned that this is a osmotic diuretic, so we're going to include things such as Foley catheter to monitor strict isonos because we're going to want to know how well they're able to pee, how much are they getting out, because that's how we're going to know how much fluid is being or siphoning out. We're going to want to know their kidney function, electrolyte function, because it is a diuretic. And because it is a rapid infusion, one of the things that could happen, what's something that could happen from a rapid infusion of fluids? Fluid volume overload. Perfect. So we're going to want to assess the lungs for pulmonary edema. And a lot of these neuro patients are going to have like 1 hour neuro checks. Someone on mannitol you'll see the increase in the, there should be, if it's effective, you'll see the increase in the Glasgow Coma Scale, increase in the level of consciousness. Okay, 3% normal saline. This one's also, they're all going to be used for reduction in cellular swelling, but this one's going to be a bit more for long term. Same thing though, we're going to be measuring the strict eyes and nose. We're going to also be assessing the long sounds. Pretty much all three of these, it's going to be we're going to be assessing long sounds. And we're going to be assessing their BMP for changes, severe changes in electrolyte imbalance. This one in particular, they do a osmolarity draw. So too much osmolarity, it's meant to be held. But overall, these do function very similarly in terms of the nursing assessments and nursing interventions. The main difference is going to be how if they're for long term versus short term versus how effective they are. So the Diamox is more of a mild thing and a long term mild thing. The mannitol is like the heavy guns, and it needs a little bit more careful management. The 3% normal saline is long term reduction, but it's also going to be higher acuity for you to kind of assess the patient. But they're all going to have the same interventions and the same assessments essentially. Here, the other things that would be included would be propofol, this medication called Precedex, and fentanyl for sedation. So the patients on sedation are going to be on these medications. Sometimes they're on just propofol. Sometimes they get propofol and fentanyl. Sometimes they get Precedex and fentanyl or some other combination. Because we have swelling in the brain, IV steroids like dexamethasone, dexamethasone, could be indicated for this because it helps decrease the swelling in the brain. Not every instance of cellular edema uses mannitol is like pretty, it's almost like the gold standard, but for a lot of the acute cases, but not everything is the answer is always mannitol. IV steroids are used in different forms of, there's different types of cerebral edema. But because it is a steroid, it's a glucocorticosteroid, this medication will increase the risk of infections. It will increase the sugar level. So body's already in like a stressful situation. So it increases the risk of hyperglycemia. So this could be a patient that might be getting insulin, even if they're not diabetic, just if like their reaction causes spikes in blood sugar. Another medication is called Nimotop. I think it's nimodidine. Is the generic. Nimodipine. Nimodipine, which is a calcium channel blocker. This one specifically, a lot of the calcium channel blockers, their main indications usually for like angina and like vasospasms. This one, it's being used specifically because you want to decrease the risk of vasospasm, so the blood vessels kind of having a spasm, because that again is stimulation that could cause an increase in your ICP. So by decreasing it, we're also kind of like preemptively stabilizing the ICP. And if they are having vasospasms, we are going to be decreasing the ICP. Okay. So beta blockers would be to maintain the MAP at certain levels. We don't want to be above 180, but it depends on what the order is for the patient if they want to be kept at a specific map or a specific blood pressure for like permissive hypertension. This would be like nitrates. So nitrates are vasodilators. Again, it's part of the game of like kind of getting it up or getting it down. Alongside your vasopressors, again, it's kind of like the game of keeping it up, keeping it down. Like how are we bouncing depending on like the patient, how are they reacting? And again, the mention again of crushing stride, because again, it is very important for this specific section. Any questions on anything we talked about thus far? Okay. The next thing would be the EBD, the external ventricular device. This is that EBD thing I looked up before, in order to kind of drain cerebral spinal fluid or whatever fluid buildup is in the brain. Again, this is there to help equalize that CPP. It can also be used to measure it. You don't need to know too heavy into detail about it. I think just knowing it exists is good enough. And knowing the general idea of what it does is good enough. I'm not I'm not sure if I remember if there was any mention of meningitis, but it is a possible post-op complication because you're being invasive, right? It's very invasive into the brain, so the possibility of meningitis is there. But I do have listed some of the things that would it be indicative of meningitis, headache, and altered level of consciousness, which are very generic, but they're part of the bigger picture. So someone with meningitis would also be sensitive to sound, sensitive to light. The important thing is the high fever and the nuchal rigidity. Nuchal rigidity meaning that they have a very stiff neck, like difficulty moving their neck because it's very, very stiff. And then there's some other things here. This is one second. The Brudzinski sign is going to be indicative of see, I think these are both like helpful for indications of meningitis. I don't remember the specifics, but let me just look it up. Kernig sign. So the Kernig sign is used to detect irritation in the meninges. So a positive sign would be is indicative of inflammation. So what should happen, or what should happen, is the ability for the knee to extend past this point without the pain. So the Kernig sign is, so here they're laying flat, their knee is set up like this, and then they are having their knee be moved up like this. If that causes pain, that is a positive Kernig sign, which is indicative of irritation in the meninges. Okay. And then the Brudzinski sign is another possible indicator of meningitis, and this is kind of what that nuchal rigidity is about. Other than like the pain and stuff, this is another thing that's like involving the neck when it comes to meningitis. So having them flat and lifting their head up could cause their hips and knees to like inherently shift up like this, causing involuntary bending of the knee, which could suggest inflammation of um, some of the stuff around the brain, spinal cord. I'm thinking the idea is because it's so inflamed, causing movement of one makes something bump into another thing, causing movement of the other thing. But if you ever see Kernig sign, Brudzinski sign, that's what that's referring to. this might be more relevant for like a Kaplan on this topic, but regardless, one of the things for bacterial meningitis is that there's a lumbar puncture in order to analyze the cerebrospinal fluid. So the cerebrospinal fluid is then taken into account. Uh, Having a low glucose that is expected for the cerebrospinal fluid and a high protein from what is expected from the cerebrospinal fluid would be indicative of bacterial meningitis. The idea, kind of like the bacteria is kind of feeding on the sugar in the cerebrospinal fluid, which is why it's low. But that's like one of the indicators for bacterial meningitis. Um, this person will be on droplet precautions. One of the main treatments is going to be antibiotics, IV fluids, just like other infections, steroids, mannitols. Same with like the neuro that we're referring to because it is causing inflammation in the brain, the meninges, but is pushing back against the brain. All of that is also increases the risk of seizures. So anticonvulsants when appropriate. Anticonvulsants would also potentially be appropriate for some of the patients, some of the other neuro patients, not just meningitis, but it's up to discretion. Some patient education would be vaccination. So certain people higher risk, they can get vaccinated. And the only other thing that is worth noting for meningitis um, is that the bacteria that causes meningitis, they when they're destroyed, they release toxins. Um, and that's actually going to be one of the main part of the meningitis is that when they get destroyed, they cause inflammation. So when you give them antibiotics, they're actually going to get worse before they get better, which is why meningitis is kind of sucky. So the antibiotics will make them worse before they get better, but it's like the only real thing that you can do to try to help alleviate what they have. There is also such thing as a viral meningitis, but that one's self-limiting, so it will be it's kind of you treat the symptoms, it'll go away on its own. Same with most of a lot of viral diseases, it just kind of goes away. It's more self-limiting, so like the pathways of the viral pathway is self-limiting in the human body. So over time, it gets fought unless you are immunocompromised, I suppose. Other things that could occur to a patient with neuro issues. So this is all like meningitis because we are invasive. Other things that could occur due to brain damage or damage to the spinal cord, or just swelling in that area is uh, endocrine uh, endocrine conditions. Have you guys gone over diabetes insipidus and SIADH before? I'm trying to remember if that's something that you guys have done already, or if it's something that you guys will do.
SIADH was briefly mentioned, but didn't go over it in depth.
Okay, I think that might be a future week, but I'll go over it real quick, just so that you have like a little bit of a preview for the upcoming week. Because I think it should be it's not in 2:30, I don't believe. So I think it's going to be later on your on in this semester. But diabetes insipidus, it's DI. You can think of it DI standing for dry inside. So this is all related to your ADH, which is anti-diuretic hormone. So this condition is low anti-diuretic hormone. So it's it's going to cause um, diuresis. So you're going to be peeing a lot because you don't have enough of the thing that's keeping you from peeing your brains out. So you're peeing a lot. Um, and it's worth noting that ADH is only controlling water um, water removal and not electrolyte removal. So like a diuretic works by actually increasing the removal of electrolytes, which then causes water to be dragged on alongside of it in the kidneys. So you lose both electrolytes and fluid. With ADH, that is directly a control of your fluid. So in this condition, you're peeing a lot, you're only losing fluid, you're not losing electrolytes. So in your circulation, you have uh, a level of salt that has lost a lot of fluid. So you become hypernatremic, but this is a um, depletion, not depletion, sorry. This one's like, what's the word for it? This one's just like hypernatremia due to hypovolemia. So hypovolemic hypernatremia. So in terms of like once if you were to be rehydrated, you wouldn't be hypernatremic because again, all of that stuff is like a concentration levels rather than raw numbers per se. So this is hypernatremia because you're hypovolemic. And some of the things that you would be noticed would be a decrease in your blood pressure because you're peeing so much. Obviously, oh, let's see, it's one for increase. Urine specific gravity, which is showing that whenever I guess this is more like urine osmolarity, but when you're peeing out, your pee is going to be very unconcentrated because you're just peeing straight up water. So the urine specific gravity is going to be low, signifying that you are just peeing water basically at some point. You're not really getting rid of too much of the toxins that are built up in the urine. You're not getting rid um, of that uric acid. It's just going to be fluid. So a low urine specific gravity. Because your blood pressure is going to be low, um, you're going to be you're going to be having tachycardia due to compensation. And of course, this is an ABC issue because you're losing so much fluid. So yeah, so this is urine osmolarity specifically. And the treatment is going to be vasopressin. Vasopressin is synthetic ADH, which makes sense. You're lacking ADH, so you get ADH. Makes sense. Vasopressin is also something that I think I made a mention before with your critical care drugs. It can be thrown in. I think it might even be mentioned here. Guess not, but it should be. So your vasopressin is given with like let's say after a certain amount of uh norepinephrine has been titrated. So let's see, I think they start you off with two, or I think no, they start you off at five mics of norepinephrine, and then you titrate up and down by two. Once you reach above 10, so like 11, for example, you will automatically add on a vasopressin at a set rate to kind of as an adjunct. Um, so that's another use of that. But yeah, vasopressin is going to keep fluid in. So it's going to help with this condition here. It does not have anything to do with blood sugar. It's just the name. The next one would be the opposite. So SIADH, which is syndrome of inappropriate ADH. So too much ADH. The SI part of it can be thought of as like soaked inside because they're retaining fluid inside. So they are retaining only water. So now you're going to have dilutional hyponatremia. The salt level didn't change, but now there's so much volume that in comparison, that concentration is low. All right, and this picture kind of goes over that. You don't really need to know any specific. I would just say get a general idea of um, why it's happening and what is one of like the major causes of it. So this is you're gonna be very much fluid volume overloaded, and you're gonna have abnormalities in your electrolytes here. Well, here you're gonna be fluid volume depleted. This picture is also something that could help here. Showing you like also like the urine. So the urine's gonna be the opposite. You're gonna have an increase in urine osmolality because in this case, when you do pee out, you're not gonna be peeing very often. Let me just type out increased urine output, increased urine osmolarity. So you don't pee very often. Everything is being kept inside because of the excessive antidiuretic hormone. So when you do pee out, it's very concentrated. Okay. That's as much as you would have to know about it, if at all, until you get into a bit more detail in a future week. But that is everything for this week. I have questions that I hand out for you guys to work on your own. And then I'm going to be doing the next week so that I can have both of your weeks done before your next exam. I will do it on Sunday around the same time. Get you guys questions. Let me see how many questions. I got like 8 questions, but every time there's going to be answers and rationales at the bottom. Feel free to type out any questions. I'll start handing out the paperwork or the form.